Syncope next.
And this is my dog, Excited. Whenever he gets excited, he freezes and falls over. It's condition, we don't know. Zach has mentioned cataplexy and narcolepsy. He mentioned it could be neurological, the fainting goat syndrome. There's been lots of things mentioned, but until we sort of. So let's go to part. Usually absolutely fine. There's certain points. There seems to be at certain points like textures on the ground for certain areas. As far as we know, he is like better, no concerns. Like life threatening, anything like that. Very happy to be carry on living a normal life. Nothing to suggest that this is going to do any damage, but obviously, it's diagnosed and definite. But otherwise, it's a completely perfect life.
I probably shouldn't laugh at that, but it's still funny. I was just going to get your minds ready for Syncope here, chapter 52, 5 pages. Right there. Here's your objectives. We will crank through this lecture and then get you guys going for the day. Not going to mess with check on learning. We can take care of that Monday. Most of these, we do not need to be worried about syncope, but obviously if somebody gets older, it becomes a little bit more concerning. Most of these are benign, so they call it vasovagal. So somebody vagals, it's just the body's way of putting somebody on the ground so that they can get things figured out for whatever reason. So orthostatic hypotension, whether that's from dehydration versus somebody that's taking, maybe they're on hypertension medication and they put them on some BPH medication, Flomax or whatever. That can also be caused by that, or they just, sometimes older folks not pay attention, or they're getting a little less lucid, dementia, Alzheimer's, that kind of thing, and they'll forget and they'll take their medication twice. So not always intentional. Most important test with a syncope, most important test, you want to make sure it's not a cardiac cause, so it's going to be an EKG or ECG if you want to be old school. EKG is going to be your number one thing. Every patient that comes in that has even a remote cause sounds like it was a syncope, fainting spell, EKG, hands down. So brief loss of consciousness is how this normally works out. Usually will resolve without any medical intervention. So it's only a small percentage within the ED. So if somebody comes in as, if they syncopize, but they tell me I felt like I was going to pass out, You think I'd treat that any differently? Nope, I don't care. If you had a syncope or a near syncope, it's probably the same causes. The same pathway, just one thing you actually passed out, the other one you almost passed out. So near syncope, don't be like, oh, it's near syncope, so I don't worry about it. No, syncope or near syncope, please, please, they hold the same risk, same risk. So, what does that equate to? About 10 seconds of disruption of blood flow, which is why we get concerned about syncope being a cardiac cause. If the heart's not pumping properly, it can't perfuse the brain, and people syncopize. So, right there, a reduction of perfusion, 35 to 50% will cause somebody to syncopize. So, what does the body do to reset? Well, if you're on the ground, laying on the ground, then it's a lot easier for your heart to perfuse to your brain. So it's not fighting gravity as much. Not directly, at least. So again, we don't have the substrates that the brain needs because there's some reason that blood flow stopped. We fix it quickly, get that person in the supine position, and allow everything to start working again. Now this Cole Framingham study, been going on since 1948. It's like 3 generations of people now that they've been doing studies. It's well over 5,000 people, and what they did is that is a heart study to figure out what ultimately the causes were for syncope. It's pretty sad that almost 4 out of 10, I don't know, idiopathic. And we got our vasovagal being number 2 there, 1 out of 5. Again, we'll find out in IV lab. And if that doesn't get you, we'll find out in ATM lab. Some things, unsightly things, blood, IVs, triggers people a lot. So there's your cardiac 1 in 10. Those are the ones we're really concerned about. And I'll show you in the next slide here, what are we worried about with cardiac, all the different things that could be. Again, in the emergency department, most of these people we work up, I'm like, I don't know what's going on, but I'll talk about some decision tools that you can use to help out with whether or not you admit somebody versus discharge them. But here's all your different things. So certainly we get concerned about all these structural cardiac things, but this is why we get that EKG. We need to rule out these dysrhythmias. And there'll be some other slides in here that will break these down. But those are just all the different type of dysrhythmias. And chances are, that's why we put these people on telemetry while they're in the emergency department. If we do get that symptoms again, see what's going on. But just a bunch of different things there. And then we also have these neural or reflex mediated. And so we get into the vasovagal. Breath holding in kiddos, they don't get what they want. Some parents get freaked out about that. You shouldn't. They will breathe eventually. Purposely not breathe at some point. You can hold it for a little bit. You can hold it forever. Go ahead and do it. Have fun. All right. Why do we want to make sure, like I said, the cardiac, doubled risk of death. And we'll talk a little bit about that. That's that pure syncope, no prodrome. Just bam, out of nowhere. It's cardiac until proven otherwise. And then again, just neurologic as well. And there's still an unknown cause. It still increases, but, and then vasovagal. Hopefully those people kind of figure out what's going on with that. You want to see what vasovagal, standing formation, lock your knees, close your eyes, and think of concentric circles. You'll definitely pass out. Here's our cardiac. Most dangerous. Above a 10% mortality rate. And again, we break that down into something structurally, which is why eventually, if we're going to admit somebody for that, we probably need to get an echocardiogram. So ultrasound of the heart to look for structural, but ultimately we want to rule out those dysrhythmias with that EKG. And there's no guarantee that that EKG is going to tell you anything if they're having situations. But again, we worry about that because of dysrhythmia or a structural lesion that the heart cannot supply the blood flow that it needs to consistently to the brain. It's an example for you. especially in older people. So there's your classic symptoms, your pathognomonic. If you ever get a question that says this person's having chest pain, dyspnea on exertion, which is shortness of breath with exertion, and syncope, that's aortic stenosis until proven otherwise. The other thing is hypertrophic cardiomyopathy. Now we should be able to see that on EKG in a younger person. So sudden cause of death in young adults, which is why if somebody said, yeah, I passed out, I said, do you have a family history of hypertrophic cardiomyopathy? But then it kind of does this biphasic thing that happens when they're young, and then it shows up again when people are old. So there's the classic symptoms. It's a non-compliant left ventricle. Doesn't function properly with diastolic and then outflow tract obstruction. Now there's 3 flavors of this. I don't need you to know this, I just want you to realize that there's 3 different kinds here, where it's dilated, hypertrophic, and then restrictive. Structural examples, which is why syncope, a lot of people always put pulmonary embolism on their differential. Syncope. So maybe there's a blood clot that's occurring in the lungs, and that's what caused that person to pass out. And then we always get worried about our older folks. That's an underlying MI. So the older folks that come in, we need to be thinking, well, what's going on? Plus, so chest pain is going to be mixed in with that. When I think, no, it's aortic stenosis, or maybe it's an MI, or maybe it's a PE. So we're going to throw probably an older person, syncope, throw a troponin in there. Yeah. Probably going to throw a D-dimer in there if we're really worried about it being a PE. Is an idea, because we're not just going to willy-nilly CT everybody's chest. And here's your dysrhythmias again. So is it too slow or it's beating too fast? Either way, too slow, it's not pumping properly. Too fast, not pumping properly. Either way. So no absolute heart rate, everybody's a little bit different. So there's no saying exactly what's too low that's going to cause this, what's too high. No exact numbers. So this also depends on how well the nervous system can compensate for this. That's why they call it vasovagal. It involves the vagus nerve. Dysrhythmias, here's some ones that we really worry about. So Brugada syndrome. So that typically relates more to potential MI. You have long and short QT syndromes. I also have this crazy catecholamine-associated polymorphic ventricular tachycardia. Yeah, I've never seen that, but it's something to be aware of. Again, if we're worried about it being a dysrhythmia, it's usually sudden onset. No prodrome. Other things we're about, WPW. I will document all that stuff. I have a syncope. That EKG shows no evidence of these specific things. WPW is probably one you can see in younger folks. What does WPW look like? Just like that. What do we see there? What do we call that? Delta wave. Good. So I see a lot of EKGs in the emergency department because every EKG has to be evaluated by a provider within 10 minutes of somebody being in the emergency department. They have a time on it. I have to write on there, no STEMI, sign it, and then date it, or time it. Has to be within 10 minutes. Delta wave there. It's a fusion beat. Faster accessory ventricular. So there's 2 types of WPW. Orthodromic, okay, which means it's going this way like a clock. Now we got your vasovagal, so neurally reflex. So what happens with this? Inappropriate vasodilation and typically bradycardia. So if you have somebody on a monitor, they will typically go down probably around 40s as the body's resetting. So lightheaded, plus or minus with the nausea, pallor, get this feeling of warmth. So usually slow progressive onset. I would see this a lot with soldiers getting IVs. They look down at it and suddenly they just start, I can tell they start getting sweaty, they're clammy in their hands, and then they're out. If you have a brand new medic, it's Find the time they killed their patient. Not kidding. Anyway, just unsightly things, unsightly things. So, all these different things can cause severe pain. You know, people that if they hit their knee, like within 5 seconds, they're gonna be on the ground, passed out. It's pain-induced vasovagal emotional distress. They got this new, somebody coined this new term, POTS, postural orthostatic tachycardia syndrome. It just has, somebody that has orthostatic intolerance. And we still don't really know why. It's new hotness. Carotid sinus syndrome. So, yep. Baroreceptor located in the beginning of the internal carotid for whatever reason. That's massaged, touched. A lot of times they say this is caused by a little kid practicing checking his grandfather's heart rate, and it causes him to pass out. Probably pretty traumatic for a kid. And then also putting on ties. Ties are too tight, so people will suffer from that. But consider that in older folks, which is why we don't do carotid massages on older people. The other reason is if they have a clot, you massage it, break that clot free, now you're just causing embolic stroke. No bueno. Orthostatic syncope. So this is why we do tilts. Usually decrease in the systolic of 20 or a diastolic of 10. So usually when somebody gets up really quick, that's why you ask them, hey, were you sitting for a while and then you stood up real fast? The body just can't handle that sympathetic output increases, parasympathetic decreases. That's supposed to cause the heart rate to increase, but it doesn't always result in increased cardiac output if we have a preload problem and they're dehydrated. That's typically the number one cause of that. Within 3 minutes, as they say when that happens. What are you concerned about is there an underlying cause with that orthostatic hypertension? For some people, they're just older, they're like, I don't like to drink water. I drink like 10 cups of coffee a day, which is diuretic. I can help out. But we need to be concerned, is it something that we can't see? Are they bleeding somewhere? And we can't see, inside their belly, GI bleed, whatever. So just think like, what's going on there? Is it a septic picture? It's causing them to be hypotensive or start to go to septic shock. Or this intravascular blood loss, either not taking enough in, they're on some type of diuretic for their high blood pressure, or they've just had some underlying sickness. So be worried about this in older folks. Be worried about this in older folks. And then there's also psychiatric disorder. It's funky. Psychiatric disorders found in 40% of people that have vasovagal, and in 62% if they don't have it. They have unexplained syncope. So it is tied with anxiety disorder, and MDD is major depressive disorder. Typically when somebody has signs of depression, usually longer than 6 months, otherwise about something else. And then there's psychogenic pseudo syncope. So again, these people are going to hold their eyes shut, be out for long periods. But that is a diagnosis of exclusion, so don't jump on that. That means you worked it up completely, don't find anything, and just tell them to go follow their primary care. Let them figure that out. And then obviously medication reduced, right there. What are our typically overused medications that cause this? People on beta blockers or calcium channel blockers. And again, it's not that older people intentionally do this. You just forget. You take too much of the medication. Other things like nitrates, maybe they have a nitrous spray or nitroprusside, and then diuretics. Again, there are side effects with medications that can cause arrhythmias, so just be aware of that. There's a lot of medications out there that can result in that. Here's a list right here. Am I going to ask you any of this stuff? No, I'm not going to ask you this, but I want you to be aware that there's a lot of medications that can cause this. That's why we ask people that are having heart attacks, are you taking any medication for erectile dysfunction? So Cialis bag or whatever. Because if we're gonna give that person nitro, we're gonna friggin' put them more hypotense. Be careful with that. But obviously the big one being your antihypertensives, which is in the realm of beta blockers, diuretics. Just be aware that alcohol and cocaine can also cause this as well. Clinical features for neurologic. So very rare that they're neurologic. So they have to be transient, there cannot be something that is constant. So what's concerning about these is if it's some underlying significant cause, concerning cause like a stroke, sepsis, or an overdose, we do not want to get that mixed up. But here's one that's a little bit more common. Subclavian steel. So you have this abnormal narrowing. This is just anatomic abnormality that these people have. So typically exercising with that arm, when I say exercising, this happens a lot of people putting boxes up in a closet. The classic example of this is grandma or grandpa putting the tree or the star on top of the Christmas tree, reaches up and then suddenly passes out. That's subclavian steel. So a lot of times when you check that, you do have to get a blood pressure in each arm to kind of compare that and get a much better idea. They're going to be significantly different from each other. They shouldn't be. They should not be. We do get worried about spontaneous subarachs. It's related to that as well. But typically, we're going to have some focal neurological deficits, complaining of headache, and then a persistent altered mental status. So, but then it's like, wait a second, but did they syncopize and now they hit their head and now they got a subarach? We're worried about that. Again, mimicker with syncope. And yes, they can have that little bit of tonic-clonic activity that somebody may jump on the board and say that's a seizure. But again, we would see all these type of symptoms that help us differentiate those things. We talked about that. They have a known history of a seizure. We have that post-ictal period, tongue biting, incontinence. We talked about all that stuff with seizures. Go diagnose it. Want to make sure that we're looking at the risk with these folks. And again, I told you, syncope or near syncope, treat them the same. Treat them the same, or you're going to get your feelings hurt. I don't want you guys to get your feelings hurt. There's learning and then there's having sound judgment. So do not treat those any differently. Make sure we get a good history on these people. Do a thorough physical exam, and absolutely 100% EKG. If that person can't remember exactly what happened, hopefully somebody was there and witnessed it. Make sure you have a good idea of the events that led up to that. Where was the person at? What was around them? Were they outside? Were they in their home? Were they working out? Were they doing any exercise? And then was there any prodrug before that? They have a headache, diplopia, double vision, vertigo, and then always asking about chest pain. So then we go into the realm of MI versus PE versus aortic stenosis, and then how long do they take? Here's your red flags. Chest pain. Don't ask patient if they have palpitations. They're going to look at you unless they're medical, and then I don't know what that is. You feel like your heart was racing, or going too slow, or beating out of your chest, or feel like butterflies fluttering, those types of things. We're all used to talking to each other and using all the medical words. Now you pick up the phone and call a consultant physician, they want all the big boy words. Can't throw out $15 words at a party, you'll get your ass whooped. Okay, shortness of breath, headaches. Those are all just what led up to that. Should give you an idea of like, do I need a full court press this or not? And then again, sudden onset without warning or with exertion, those are very concerning things as well. That's cardiac and tool proven otherwise. You can ask all these other different types of questions. I'm not going to sit there and rattle off each one of these. This is just what you need to be thinking inside of your head. Maybe you need to ask more pointed questions with older folks, just because sometimes they're poor historians. More likely, if this is like, oh yeah, this has happened to me like this, like 6th time this year, more than likely, we can rest assured it's probably a vasovagal. But if they came in the ED today and they never came before, well, what was different today? Ask them that. And then, of course, any medications that they're taking, any change in medications, give you a good idea. There are a lot of people out there that will take laxatives to try and lose weight, or they're on phentermine and all these other different weight loss medications. And everybody knows that plenty of soldiers that take all kinds of different supplements, not necessarily pre-workout, whatever. I'm not saying it's bad, I'm just saying there are websites to check and make sure. There we talked about that. If they are aggressively dieting, maybe they're not taking in enough electrolytes, and they're taking medications they shouldn't. Very strong family history. Do you have any family history of any heart conditions? Heart conditions. There's do run hereditary. On QT syndrome probably being one of the big ones there. On QT. So, and then anytime it's a single car accident, you need to be thinking, did that person syncopize? Single car accident, because most times people are in accidents, it's 2 cars. If it's a single car accident, how did you wreck it? Just your car. You sure you didn't pass out? Not everybody's going to be honest. Some people come into the emergency department because they're brought by EMS. Older folks sometimes don't want to get admitted to the hospital. That's fine. You don't want me to admit you. You're going to sign right here against medical advice. I want to go home. This means that I'm free and clear if anything bad happens to you. So, seizure being the most mistaken event, because people syncopize, they have that little bit of brief tonic-clonic. Again, we've talked a lot about seizure and how we differentiate. Is everybody clear on that? What we look for with seizure versus syncope, right? Get our safety net. Like I said, if somebody's syncopized, I'd rather have my safety net in place, IV fluids, maybe giving them at least filling up the tank if there is any concern for hypotension. So, now we get concerned if maybe it is a hemorrhagic emergency that's underlying, so large bore IVs if needed. 14 gauge ideally, but if you had 2 and you're 18, it's be just fine. Then I don't reach for O2 until somebody's typically below 90%. So if somebody's like 93, that's about what most people sat at, especially older folks. And then I get them hooked up to a cardiac monitor, absolutely. And that you have to order in Genesis. I'm not just going to put them in a room and do that. You tell the nurse, hey, put them on a monitor. You actually put the order in just to make sure what bases are covered. And then obviously doing tilts. If you're really worried this person's a high risk and they're having some underlying dysrhythmia, put pads on them. If I am treating a supraventricular tachycardia, I've done all my vagal maneuvers. What's the first medication I'm reaching for? I'm reaching for adenosine. And it's a fast push, 6 milligrams. I don't push adenosine until I have pads on a patient. Just for some unknown reason, they go into a lethal arrhythmia. So think about that with syncope in somebody that's old, they doesn't look good, they look sick. There's potential, better to have the pads on right away. Now, person has evidence where there's no defensive injuries. Trauma in Tacoma, I had a 65-year-old gentleman who was working on a roof. Came in, he'd fallen off the roof, busted his face up. His dentures were shattered probably into 5 different pieces. The weird thing is his face was all busted up. Nothing with his hands. I'm pretty sure that guy probably syncopized for whatever reason. And maybe herniated, busted too bad in the face, but there were no defensive injuries. If somebody had fallen off a roof, you would expect they would try to catch their fall at some point. So, again, orthostatic blood pressures, you get tilts on these folks. Decrease in the systolic, they're symptomatic of 20. or if they're under 90. Do a good cardiac exam. Probably why we stress it here so much, but you're pretty much listening to each other, which is normal. You can listen to any number of things on the internet, so you have an idea of what these are going to sound like. If there's underlying hokum or aortic stenosis, obviously good neuro exam, full neuro exam on these folks. And then plus and minus on the rectal exam. Most older folks don't look in the toilet after they go, so they could be bleeding. Again, I said no carotid massages. It's not causing embolic stroke. But our history, a lot of these tests, we're just making sure that there's no underlying cause. They're not going to give us answers. But what is that EKG. EKG. And then a lot of times we'll observe these people from anywhere from 2 to 6 hours. 2 to 6 hours. And I'll explain what the CSRS is here. And make sure that we're looking for all these other things. That EKG is going to help you eliminate all those. Left bundle branch block. Anybody tell me what that looks like? So, widening of the QRS, okay? Usually greater than 120, good. You guys didn't dump all that yet. So, usually negative QRS in V1 and then notching QRS in V6. Right. Lab testing, older folks, we just probably gonna get a lot more done to make sure that YX positive, that it's gonna mean we're gonna need to get a CBC, get an HCG in pregnant patients. Make sure we get those pregnant patients. And then we wanna make sure, if you want to, you can get a lactate. Look for that anion gap acidosis. And then we want to get a troponin because we're about MI. And then what is the BNP going to be for it? BNP. CHF, right? CHF. That's how you differentiate CHF from COPD. When somebody with shortness of breath. That BNP is going to be elevated, or pro-BNP based on your UTI. This is what Tip Nally has in there. I think it's ridiculous. I would never purposely cause somebody to hyperventilate, but you said that that's how you can reduce that. You find that's more of an anxiety-driven thing. And then, unless you have CT findings or history of head trauma, I don't really go down the road of CTs, EEGs, LPs, unless you have those. And then again, a lot of people will work up a PE. They're worried about syncope. But I also want to see syncope with chest pain, and specifically pleuritic chest pain. And when I say pleuritic, that means they have the pain increases when they take a deep breath in. That's a PE until proven otherwise. Okay, if we identify that cause, we need to make sure that we get them figured out. Okay, cardiac or neurologic. Well, if it's obviously cardiac, you're going to involve the cardiology team. If it's obviously neurologic, involve the neurologic team. If you're not sure about where it is, internal medicine will pretty much take any one of those. No need to increase if we're talking about vasovagal, orthostatic, or medication, but we do need to figure out what the offending agent is or what that was caused. Are they just dehydrated? Do they have diarrhea? They've been vomiting? Or taking too much of their medication? That is, I told you I would explain this. This is the Canadian Syncope Risk Score. You're going to use a lot of these tools, these evidence-based tools, to help you out in the emergency department. They help you out in two ways. They help you to get somebody admitted, and they help you if you want to discharge somebody. If you have a 0, you can probably go home. If you have any number of things, make a decision on whether or not they need to come in. And here's all the difference right there that they look at. So obviously if they have a predisposition to vagal syncope, it's likely it's going to decrease the score. Heart disease, systolic blood pressure, all these types of things. So as you can see, you have to have an EKG to utilize this tool. Here you go. I know it's a little bit small. I'm not going to have it calculate on the test. I just need you to be aware that this is out there. You can see how that works. works out as far as points. If you think it's vasovagal, you can take off a point, and if you diagnose it as vasovagal, you can take 2 points off later, so. Gotta be pretty sure that's vasovagal though. How's that work out right here? Where's my cutoff? I'm gonna say about 3. If it's a 3 and I call them and I pick up the phone and I'm talking to neurology, I just say, hey, bottom line up front, I got a guy down here, syncope, but I got a Canadian syncope risk score of 3. You come down and see the patient. Or do you want to hear the whole spiel? Most of the time they're like, no, got it, I'll be down. Sometimes they're like, yeah, tell me about it. And, film for 5 freaking minutes. But anyway, great tool to say, that person's at a -3, I'm going home. Person's at a -2, whatever. So you'll have your line in the sand with where you think that is. I have patients coming by, I just got hypoglycemic today, and I get their EKG and I add up the score, and I'm like, one of my residents like, I think I'm gonna send him home. I'm like, it's got a score of 4, dude. You're okay with that 8.1%? Okay. No, I'm not gonna let him feel like that. Call him up, get a patient visit, let's go. Right there. So, to monitor them in the emergency department, but if they get a high enough score, I'm gonna bring them in. So, and these percentages are just all out of percentages of people that ended up coming in that did not survive out of the hospital. That's why it says all deaths. So very, very high risk patients, 9% of those patients that were admitted that were high risk did not make it out of the hospital. That's 1 in 10. Doesn't sound like that much, but when you're talking about 500 million people, yeah, good ballgame. EKG is optimal. Why if we're worried about cardiac, we're going to bring them in, they're going to make sure they're going to put them in a room where they put on telemetry, which means they're going to monitor their cardiac activity the whole time. In the event that they have those symptoms again, they can collect it and print it up. So maybe they're having bouts of SVT, maybe they're having paroxysmal atrial fibrillation that only happens a little bit at a time. I definitely worry about the older folks, people with history of coronary artery disease. It's nice in the emergency department if somebody's older that I just tell one of the techs, hey, can you print up their last EKG? So I can go bam, bam, and see if there's anything different and compare it with an old one. Troponin levels, yes, there are people that live out there that have what's called troponemia. They always have an elevated troponin level. That's a good thing to know when the troponin comes back positive. By the way, when it comes back positive, a nurse will say, hey, at the lab on the phone for you, they got a critical value. Now you're cooking. Now you know something's going on. Anyway, systolic, and then anything it's worried about. Cardiac syncope. Pure syncope. Okay, treatment, based on the diagnosis, there's potential these people have significant enough heart block or they're bradycardic enough that they do need a pacemaker. Lung QT syndrome is going to require an implantable defibrillator. Maybe they get medications, but that's typically going to be in concert with a specialty consultant. I don't go just putting people on willy-nilly medications from the emergency department other than to treat some of their symptoms. It's good to just give. Not everybody needs fluids, but in these cases, if somebody's hypotense, go ahead and give them some fluids. And typically that CBC will show significant saturation with an increased H&H because they are volume down. And then just education for these people so they don't freak out. Like, why do I see blood, I pass it all the time. It just happens, some people, that's how they're wired. Low risk goes home. Intermediate risk, plus or minus, based on your gestalt, based upon shared decision making with the patient. Hey, I want you to get into your primary care, when can you get in and see you next? My next door neighbor's my primary care. Okay, cool. Nah, I'm okay with you going home. And high risk, those people need to come in. Those are all our different types of things. Exertional, we're concerned about acute coronary syndrome. We have some type of ventricular arrhythmia. So if they have cardiac device or then any concerning EKG findings, that's difficult if you don't have a previous one. It's just nice to be able to go with those two. Cool. How's that? Good? We will do check on learning on Monday, because that's what we're gonna do. Now we have 4 lectures and they are all short. So we'll just bring through Monday and then I will have you out early on Wednesday. Thank you for your time.
How do you put up with it?